الله الرحمن الرحيم. هو اليوم المواضيع في وقت الأسنان يحتاجون بداية introduction about local anesthesia. What the work of local anesthesia is formed from highly specialized nerve cells called neurons, which can receive stimuli from receptors over all the body and deal with them and finally send a proper impulse to the effectors. The connective tissue that is associated with each neuron is composed of special material called myelin, which is itself made up of cell bodies of specialized cells called Schwann cells. This figure shows the nerves and the nerve fiber that are surrounded by the axon by the nerve sheath is from Schwann cell. The nervous system have many cranial nerves. There are 12 cranial nerves. The most important cranial nerve for dentistry is the fifth cranial nerve, is called Tridemian Nerves. The Tridemian nerves have two roots. From the first is the largest root that is called it sensory root, and the smallest root is the motor root. Is start from the brain stem. These two roots to the trigeminal ganglia, and from the trigeminal ganglia divided through three divisions: the V1, V2, V3. The V1 is the ophthalmic division, and V2 the maxillary division, and V3 the mandibular division. The trigeminal nerve divided into ophthalmic division V1 is purely sensory, and maxillary division V2 is sensory and autonomic nerve, and the V3 mandibular is motor, sensory, proprioceptive, and parasympathetic nerves. This figure shows the branching of these three divisions in all parts of the head of the person. We start from the trigeminal nerve. The first division is ophthalmic division is V1, divided into three branches: the frontal, nasolacrimal, and lacrimal, nasociliary and lacrimal. The frontal nerve branch to two divisions, supraorbital and supratrochlear. The supraorbital branching in the supply the supraorbital notch foramen, mucosal membrane of frontal sinus and conjunctiva of upper eyelid and forehead as far as the vertex. The supratrochlear supply the middle of forehead to the hairline. The nasociliary divided into three nerves: infratrochlear, anterior ethmoidal, and posterior ethmoidal, and this supply the branch of just infratrochlear branches of just before the nasociliary anterior ethmoidal foramen, run along the upper border of the and is joined near the polli of by filament from the supratrochlear. It then passes to medial corner and supplies the skin of the eye and the conjunctiva and lacrimal sac. It supplies the root and bridge of nose, middle upper eyelid, and lacrimal sac. The anterior ethmoidal is in external nasal and supply the nasal bridge and emerge between the nasal bone and the cartilage and supply the dorsum of the nose. And the last one is the lacrimal nerve. Many nerves, the last branch is the posterior superior alveolar nerve that emerge from the two foramini in the posterior surface of the maxilla to supply the third molar, second molar, and distal buccal nerve of first molar, and emerge through a canal within the maxilla and divide into middle superior alveolar nerve that supply the mesovocal root and the palatal root of the first molar and second premolar and first premolar. And in last with two nerves. The first one is called anterior superior that supply the root of the central, lateral, and canine, and reach to the infraorbital foramen, and that emerge as infraorbital nerve that supply the gingiva and the labial mucosa. We have other nerve from maxillary nerve is called greater palatine nerve that have within greater palatine canal and divided to one nerve branch. The first one is greater palatine nerve that go through greater palatine foramen and within greater palatine groove that supply the palatal mucosa of heart palatal to the between the first and second premolar that end with the premaxilla, and other branch the lesser palatine nerve that supply the soft palate. Other branching of the maxillary nerve is nasopalatine nerve. The nasopalatine nerve that emerge within the medial nasal septum and go anteriorly and downward until reach the incisive foramen and can pass through incisive foramen as a nasopalatine or incisive nerve that supply the lateral mucosa in premaxillary branch. The last division is the mixed nerve that have the mandibular division of trigeminal nerve that emerge from foramen ovale and divided to anterior branch and posterior branch. The anterior branch is mainly motor except the long buccal nerve. The posterior branch is mainly sensory except the hyoid nerve. The posterior branch divided into main branch, the lingual nerve that is an inferior nerve that pass to the through the middle surface of the ramus of the mandible. These two nerves go downward until reach the retromandibular space that the lingual nerve passing within the beneath the mucosa of the floor of the mouth and supply the lingual gingiva and the anterior two-thirds of the tongue. The inferior nerve emerge within the inferior mandibular foramen and inferior canal that pass to the through it and supply all mandibular teeth until reach the mental foramen. And this divided into nerve. The nerve that emerged from the mental foramen called mental nerve that supply the labial mucosa, lower labial mucosa, and they are part of the gingiva in front of the anterior teeth. The other branch that have called it incisive nerve that supply the canine and central and lateral lower incisors. This diagram shows the branching of the mandibular division that emerge from foramen ovale that the main trunk is supply the branching to the middle pterygoid muscles and the nervus spinosus and divided to anterior and posterior division. The anterior division is mainly motor to the muscle of mastication, the temporalis, lateral pterygoid, masseter, and we have one sensory is called buccal nerve. The posterior division is sensory as auriculotemporal, inferior lingual nerve, except the mylohyoid branch supply the mylohyoid muscle. The simple anatomical landmark of the skull, the anterior part of the skull is the facial bone as a face. We have many facial bones, and the most important one is the maxilla form that upper jaw and the mandible that form the lower jaw. The maxilla is the have upper arch that it is mainly is cancellous bone, and there's thin cortical bone labially and buccally and palatally. So the anesthesia can easily penetrate through the cancellous bone as a spongy bone in the upper jaw. Lower jaw is the mandible that form two parts, the body and the ramus, and the body is that hold the upper lower anterior lower teeth that have mainly compact, the little of cancellous bone that form the mandible. So by aging, the in child is cancellous is anteriorly is larger, and posteriorly due to the presence of the external oblique and the minor ridge that form big and compact bone that have give other type of anesthesia. This is the anatomy of the maxilla that form the body and for a process. The frontal process, the zygomatic process, and the alveolar process. We have infraorbital foramen and the between two sides of maxilla intermaxillary suture, and we have the orbital plate or orbital process. This figure shows the all from the body from anterior view. This figure shows the body have in the is not solid bone. It have a cavity called it maxillary sinus. The nerve that have supply the upper jaw from the maxillary division through the posterior, middle, and superior alveolar nerve. At the roof of the mouth, they have the hard and soft palate. Anterior two-thirds is the hard palate, and posterior third the soft palate. The hard palate is formed two bone. The anterior two-thirds the palatine process of maxilla, and posterior third the palatine bone, the horizontal part of palatine bone. This figure shows the mandible have two parts, the body of the mandible and the ramus. The body is horizontally in its position. It have two parts. The upper part is alveolar process, and the lower part is the base of the mandible. We have in the anterior surface the mental foramen between two roots of the first and second premolar, and we have external oblique ridge that go within the anterior border of the ramus that form the anterior that form the ramus of the mandible. The ramus is square in shape that have connection with the body by the angle that form the angle of the mandible. And we have at the upper border two processes, the anterior one coronoid and the posterior one condylar process. The muscle of the facial expression and muscle of mastication that all have origin or insertion within the mandible. From medial surface, we have the body. The main process is the mylohyoid ridge that starts from the symphysial region and go upward and posteriorly until reach the anterior border of the ramus. Divide this ridge and superiorly the submental space and inferiorly the submandibular or submaxillary space that contains sublingual or submandibular salivary gland. We have at the ramus the main foramen in the within the occlusal surface of the lower teeth is called the mandibular foramen that go to the inferior alveolar canal. Well, now we start with the simple physiology of the nerves. The physiology of peripheral nerve. The function of the nerve to carry message from one part of body to another as electrical action potential called impulse, which initiated by chemical, thermal, or mechanical stimuli. So, we have amplitude and shape of impulse remain constant regardless of change in the quality of strength of stimulus and the distance traveling through the nerves. فلهذا impulse لا تتأثر بالسيركيليشن and the distance, so can travel through the body within the millisecond. How the pulse information? The conduct as an impulse. We have the simple minerals within the nerve cell. Inside the cell, the concentration of potassium is more than outside. And outside the cell, we have sodium. We have node of Ranvier between two myelin sheath cell. The myelin we have when have impulse function, they are actually complex electrochemical structure. The electrical event that occur within the nerve during conduction as impulse through this step. We have three-step information of impulse. The first step, there are potassium and sodium and chloride ions. The potassium ion is positive in charge. The extracellular 3 to 52 EG per liter, and intracellular 110 to 170 milliliter EG per liter. Approximation ratio 7 to 1 from extra to intracellular. The sodium is a positive charge, extracellular is 140 and intracellular 5 to 10, and the ratio between intra to extra 1 to 14. Chloride is negatively charged, the extracellular 5 to 10 and intracellular 110, and the ratio between intra to extra 1 to 11. So the positive charge is mainly extracellular, and the negative charge is mainly intracellular. In resting state, the nerve membrane is slightly permeable to sodium and freely permeable to potassium and freely permeable to chloride. When second step is start, we have a stimulus exert the nerve, leading to the following sequence of events. The first one is and the threshold phase and rapid depolarization. The first phase is initial phase of slow depolarization. The electrical potential within nerve becomes slightly less negative. The second phase is the threshold potential or firing threshold, when the failing electrical potential reaches a critical level and extremely rapidly phase of depolarization result. The last phase is the rapid depolarization, result in reversal of electrical potential across the nerve membrane. The entire is no electrical positive in relative to the exterior, which about plus 40 millivolt. The change in polarity between the intracellular and extracellular, the change in go to positively charged intracellular until reach plus 40 millivolt. The last stage, the step 3, the following the depolarization or repolarization occur, the electrical potential gradually become more negative inside the nerve cell relative to outside until the original resting potential of minus 70 millivolt is again achieved. So return to rest position of the nerve. This 3-step, that entire process of step 2 required 0.3 millisecond, and for step 3 required 0.7 millisecond, and for both step 2 and step 3 need 1 millisecond. The preceding sequence of events depend on two important factors. This occurs according to the concentration of the electrolyte and the permeability of nerve membrane to sodium and potassium ion. This figure shows how the change in the sodium through sodium channel that enter from outside to inside and from inside to outside, that forms the go to from the negatively charged to positively charged when enter the sodium to inside the cell and formation of impulse. We have two types of the nerve cells. One is called myelinated and other called non-myelinated. If the myelinated cell that surround the axon called a myelinated nerve, and we have two nodes between its two nerve cells that call it nodes of Ranvier. The impulse transmitted through myelinated nerve is rapid due to jumping of the impulse between node of Ranvier to the other node of Ranvier. But in the non-myelinated, they transmit along the course of axon nerve, so it is less rapid. The impulse of nerve, this figure shows how it go from outside to inside. The inside cell is 9 or 70 millivolt, outside is more positive, and change from the positivity to negativity to positivity and formation of impulse and return to its position. We have a salutary conduction occur in myelinated nerve. The impulse jump from node to node where depolarization takes place. What now go to what definition of pain? Al-alam. The pain is distressing sensation as of soreness or as disruptive sensation causing suffering or distress. Other definition of pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. The pain is the most common reason for physician consultation. It is a major symptom in many medical conditions and can significantly interfere with the person's quality of life and general function. The psychological factors such as social support, hypnotic suggestion, excitement, or distraction can significantly modulate pain intensity or unpleasantness. The pain can be divided into two components. We have the formation of pain, we have the presentation of pain, and reaction to pain. What means of pain? The end organ which subserve pain are free non-modulated fiber. The application of electrical, thermal, chemical, and mechanical stimuli may produce an impulse or wave of excitation in the nerve fiber, which is self-propagation and of uniform intensity because each fiber obeys all of non-law. So, if stimuli is sufficient to produce an impulse at all, the resulting impulse of a uniform pattern cannot be magnified by increasing the amount of exciting stimuli. إذا قانون we have قانون اسمه none or law، أما موجود أو لا توجد، أما تتكون الإمبulse by stimulation external stimulation أو لا تتكون الإمبulse. فإذا وصلت إلى حد أن تتكون الإمبulse راح تكون ثابتة ولا تتغير بزيادة stimulation. The severity of pain depends on the number of nerve fibers that are activated and not by the alteration in the size of impulse converted by individual nerve fiber. فلهذا شدة الألم تعتمد على عدد nerve end that stimuli in the area of the external surface of the body. The stimulus is conveyed along neural pathway to the thalamus, sharp pain being conducted by peripheral nerve fiber within axon core of large diameter than those which convey dull pain. في هذا الأكزون اللي بيه فايبر هواية راح يكون more sharp pain than الأكزون اللي بيه فايبر بأكزون قليلة راح يكون dull pain. The second part of the pain reaction. What occurs after the pain is formed in the body is integration and appreciation of pain within the central nervous system, which is cortex and posterior thalamus. This is a variable factor which accounts for clinical observation that intensity of pain and the patient response to it may vary not only between individuals but also from time to time the same individual. ردة فعل الإنسان للألم ايش راح تكون؟ هو البين رياكشن. فلهذا هذه ردة فعل تعتمد على شدة الألم وتعتمد على فترة الألم ومن وقت لوقت بالنسبة للشخص نفسه. What means pain threshold? Pain threshold is when the variable response to pain هي ردة فعل البين رياكشن هو راح تعتمد تقال إلى pain threshold. The high pain threshold when the patient exhibits little or no reaction to painful stimuli, but low pain threshold is liable to react voluntarily to identical or even lesser stimuli. إذا كان high pain threshold فلهذا الستيمولاي قد ما يكون strong patient ما يحس بذاك الألم، بس low pain threshold simple stimuli that patient feel a severe pain. What the factor which determine the level of tolerance of pain threshold? The first one, psychological makeup, the fear and apprehension of lethal pain, the fatigue, and the age of the patient. How control of pain? Pain may be controlled by interruption of the neural pathway at various levels and by different means which can produce either permanent or temporary result. The first the medication that have stop pain called it analgesia. Analgesia is loss of pain sensitive and accompanied by loss of other form of sensitivity. We have many sensations in the body: the pain, pressure, chemical, physical. This can go within the not go within the analgesia. Only pain is can stop it. The other drug, the anesthesia, is loss of all form of sensation, including pain, touch, temperature, pressure. Precipitation may be accompanied by impairment of motor function. And then anesthesia, all type of sensation, all type of nerve, the sensory, motor, and the various other secretomotor nerve fiber that affect by anesthesia. We have two categories for analgesia or anesthesia. The first one call it local analgesia or local anesthesia when part of body is affected. فقط المنطقة اللي تعطي فيها الانالجيزيا والانستيزيا راح تتأثر nerve fiber. We have general analgesia or anesthesia when all body is affected. في حال كل جسم يتأثر بالانالجيزيا or anesthesia call it general. The short history about the anesthesia. This simple chemical was first manufactured in 1772 by Joseph Priestley in England. Priestley was a pioneer of chemistry وكيميائي اكتشف الchemical structure within the body. The history of local anesthesia started in 1859 was cocaine, which was isolated from coca leaves by Albert Niemann in Germany. حقيقة ثمرة الكوكا هي من الأقدم اللوكال أنستيزيا استخدمت بالعالم من قبل العالم الألماني في سنة 1859. The very first clinical use of cocaine was in 1884 by Sigmund Freud, who used it when a patient from a morphine addiction. حقيقة استعملت الكوكايين من قبل الأطباء النفسية لعلاج الإدمان على المورفين أعطوا الكوكايين ولكن صار إدمان على الكوكايين. In 1884, the ophthalmologist scholar was the first who used cocaine for topical anesthesia and ophthalmological surgery. As in 1884, Dr. William Stewart Hulst was the first to describe the injection of cocaine into sensory nerve tank to create surgical anesthesia. And in the same year, regional anesthesia in oral cavity was first performed by surgeon Hasted when he removed wisdom tooth without pain. A number of adverse effects were observed within the clinical use of cocaine. Those other local anesthesia agents had to be developed in 1905. Inhorn reported as synthesis of cocaine, which was the first ester-type local anesthetic agent. Cocaine was the most commonly used local anesthesia for more than 4 decades. In 1943, Lockhart synthesized lidocaine was our first modern local anesthetic agent. Since it is a mid-derivative of diethylamine acetic acid, lidocaine was marked in 1948 and is up to now the most commonly used local anesthesia in dentistry. in the worldwide. Through other 9 local anesthesia were introduced into clinical use. The other local anesthetic agent, mivicaine in 1957, prilocaine in 1916, vivicaine in 1963. In 1969, articaine was synthesized by the chemist Monsieur Koch and was approved in 1975 as local anesthesia in Germany. Thank you for your attention for this lecture.